Welcome, everyone. Our workshop session, W33, will be on promoting teamwork. Your moderators for this session will be Preeti Varghese, the nurse practitioner, QI, and program coordinator with the Pediatric Cystic Fibrosis Program at Children's Health in Dallas, and Cheyenne Pai, the respiratory therapist, QI, and program coordinator with the Pediatric Cystic Fibrosis Program at Dell Children's Medical Center in Austin. Both Preeti and Cheyenne do not have any relationship to disclose related to this presentation. We are very excited about this session as we both wear multiple hats in our CF centers, and we know the importance of teamwork. Successful teamwork can make a huge workload of unmanageable tasks manageable. However, unsuccessful teamwork can leave team members struggling to cope. Our goal for this session is highlight ways in which centers use teamwork to open up the lines of communication with patients, families, and interdisciplinary personnel. In order to do that, we aim to deliver quality patient-centered care. Culture of teamwork at multiple levels can be instilled across the organization, professionals, and with patients and their families' partnership. Working together as a team requires collaboration and enhanced communication between all members to make decisions as a unit. It is important to assess current practice and identify areas of growth when it comes to overall teamwork. Increasing trust, open and respectful communication, and good working relationship within the team and patients, parents, enhance the partnership to work well toward a common goal. Our objectives are as follows. Identify barriers to teamwork and brainstorm solutions. Differentiate and compare delegation versus sharing the workload. Discuss how patient, parent representatives, and non-nursing disciplines can lead and enhance teamwork. We have selected abstracts for the session presentation that aim to target one of these objectives. We have a versatile group of speakers that practice on a variety of settings, pediatric and adults, and they will share how they use teamwork in their own centers to address issues such as telehealth, annual patient goals, and transition to adult care. Our speakers are as follows. Preeti Varghese, pediatric nurse practitioner from the Pediatric Cystic Fibrosis team at Children's Health in Dallas. Her talk will be on telehealth tag team, implementation of a multidisciplinary telehealth visit. Next, we have Abby Nicom, a licensed clinical social worker from Orange County, California, and her topic will be on co-producing patient and family annual goals in a pediatric cystic fibrosis center, a multidisciplinary approach. Then we have Sharon Mcnamara, a research nurse manager from Seattle Children's, and she will be speaking on preclinic review and team communication during transition in cystic fibrosis clinic care. Followed by David Miller, a physician from Banner Adult Cystic Fibrosis Center in Tucson, Arizona, and he will be talking about rethinking the cystic fibrosis care team, a novel telehealth structure, promotes interdisciplinary care and improves understanding of team member roles. Lastly, we close off with Phoebe Long-Franco from Dell Children's Pediatric CF Center in Austin, Texas, and she will close out on resiliency training for maintaining, improving the cystic fibrosis staff's mental health. Please note, our session will have a panelist Q&A format, which is different from the traditional Q&A after each speaker. We will all listen to the presentations first and do a group Q&A at the end with the speaker panel. Thank you very much.
Hi, everyone. My name is Preeti Varghese, and I am the nurse practitioner, QI, and program coordinator for the Pediatric CF program at Children's Health, UT Southwestern in Dallas, Texas. I'm very excited today to not only moderate this session with Cheyenne, but also to share how our pediatric center used and learned about teamwork during telehealth visits. I do not have anything to disclose. As this session is on teamwork, I thought I'll start by introducing my team. This is our CF team, or the Dream Team. This is the team responsible for 300 pediatric patients in Dallas. We're a closely knit team that works together to make lives better, not just for our patients, but also for one another. This is our telehealth story. Telehealth medicine was new to much of our CF team, but not to our institution. Psychology was the only department familiar and active on virtual visits prior to the pandemic. Emergency credentialing and approval for all physicians began first, then trickled down to advanced practice providers. Second-tier credentialing included dietitians and physical therapists. Social work was the last to be credentialed. Our institutional virtual health department offered training and instruction on how to conduct virtual visits using the American Well platform. Patients were notified of virtual visits and given instruction either by phone or MyChart on how to prepare for their virtual visit. We joined the CFLN Telehealth Innovation Lab in March 2020 to work on integration of multiple disciplines into the virtual visits as standard in clinic. Virtual visits for us started April 2020. Our aim was to increase percentage of successful multidisciplinary telehealth visits from 0% to 95% by December 2020. CF Learning Network Innovation Lab identified successful multidisciplinary visit as one with at least one discipline other than the provider and nursing staff dyad already participating in clinic visits. Visits can be synchronous, within or adjacent to the visit by the provider, or asynchronous, in which the visit is within 1 week prior or following that of the provider visit. For our team, for this project, we decided that we will focus on 2 or more team members synchronously seeing patient on a single call on the same day. This meant we had to, as a team, quickly figure out a process that will accomplish this goal. One of our first steps was to come up with triage guidelines as a team for our schedulers and nurses to utilize to see who would meet criteria for telehealth and who would need an in-person visit. These are a few of our telehealth guidelines. Patients who live out of town hours away, patients who did not do spirometry or patients who had home spirometers, patients who were clinically stable in terms of lung function and nutritional status for the past 3 months, and patients who are immunocompromised and had increased comorbidities. Our in-person clinic criteria included decline in lung function and recent antibiotic use, those who were on active NTM or ABPA treatments, those with poor nutritional status, those who needed to be seen for sick visits, those with advanced lung disease, any patient with social concerns or CPS involvement, foster care placement, and our out-of-state patients who did not have telehealth approval, and also all of our new diagnosis babies. We started this project by creating process maps for the team and for our patients. Our patient family partner, Tracy, was able to help us with creating the process map from a parent perspective. This has been tweaked during the Innovation Lab, and this is our final process. It starts with the family gathering vital signs, height, weight, lung function, temperatures. Then they log into Amwell 10 minutes prior to the scheduled visit and answer the pre-visit planning questions and enter their vital signs. Patient is then placed in the provider's waiting room and connected when the provider is ready. Team members who needed to see patient joins provider and visit is done concurrently. After visit summary is seen by the family on Amwell and over MyChart. The process ends with the next visit being scheduled. This is our team telehealth process. It started by provider going in and logging into our telehealth platform, Amwell. Then the nurses create an Epic chat specifically for telehealth session and adds all the team members. This is when we also decide who on the team needs to see each of these virtual patients. Then when provider sees patient in the waiting room, the team is notified over Epic and the patient is checked in. Team members are then invited by the provider via email on Amwell app, and the visit is started. Patient is seen by provider and other team members. The Epic chat is utilized during the visit to communicate with team members on call and not on the call. When the visit is complete, a scheduler is notified and she will make the next appointment. These were our interventions for this project. Weekly PDSA cycles to trial different groupings or bundles of team members on a single call, increasing our telehealth sessions to 60 minutes rather than 30 minutes in order to accommodate the multiple team members. Customizing triage questions on the Amwell app for parents to fill out prior to the visit. For Amwell, our pre-visit questions are as follows. Are there any team members you would like to talk with? What medication refills do you need? Do you need any NEP supplies? Then when home spirometers were sent out, we added, what is your home PFT? I do want to take a minute to mention that these questions for our pre-visit planning was done in conjunction with our Parent Advisory Council and their valuable input. Finally, creating a telehealth epic chat that was utilized by all team members to communicate in real time. Here are our tag team bundles on the virtual visits: pulmonary and GI, GI and dietitian, pulmonary and RT, pulmonary and dietitian, pulmonary, GI, RT, dietitian, and social work, pulmonary, dietitian, RT, and so forth. These groups were decided prior to the virtual visit and or during if indicated by the patient or parent. Here is the run chart that shows what percentage of our telehealth visits were multidisciplinary. The blue bar represents patients seen virtually in a month, and the red bar represents patients who had a multidisciplinary telehealth visit. The green line is the percentage of multidisciplinary visits as well. As you can see, we started off with lower visits in April, and this was also when we were getting team members approved and credentialed for telehealth. In terms of multidisciplinary visits, by July, we had gone from 64% to 88%. And for the most part of 2020, we stayed around 75% to 83% of virtual visits being multidisciplinary. While we did not meet the goal of 95% as set by the iLab, we were still able to reach sustainability, which is anything about 80%. Here is a graph detailing the number of telehealth patients per month, along with the breakdown of how many team members were seen. The orange bar represents patients seen by one team member, either GI or PULM. The gray bar are patients seen by two team members. Yellow bar is 3 team members, and light blue bar is 4 team members. The white bar are the patients who were seen by 5 or 6 team members on the single call. This graph also shows us the telehealth surge in the summer of 2020, mainly from May to July. Then we see a dip when school started in August, and then a spike again during December winter holidays. When 2021 started, the number of telehealth visits also decreased. Currently, we have only a handful of telehealth visits each month. This line graph details the percentage of patients seen by team members. 24% were seen only by one team member, either the GI doctor or the pulmonology provider. 32% were seen by 2 team members. The top 2 team member bundles were GI and dietitian and pulm and respiratory. 26% of patients were seen by 3 team members. Top 3 member bundles were pulm, RT, RD, and GI, pulm, and dietitian. 13% were seen by 4 team members, while only 1 to 2% were able to see 5 or even 6 team members. I would like to conclude with some insights on teamwork from our team. We felt that having an epic chat was most useful as it helped us communicate and delegate tasks in real time and in a clear and direct manner. We learned that the top team member bundles that worked over telehealth can easily be translated into an in-person visit. We saw that during the overall telehealth session, our medical assistant and our nurses took the lead in terms of directing the flow, while the provider took the lead during the virtual visit to direct and manage the other team members' participation. As we were working mostly remotely during 2020, our team had to be adaptable. There were many days when the whole system would crash and we had to switch to providers using Doximity on their cell phones and texting links to families and other team members. There were also times when either the video or the audio wasn't working on the Amwell, and we would have to toggle back and forth on the chat feature on the app. All of this we learned to be adaptable and flexible. Another important lesson was learning to be comfortable to delegate tasks to one another. When you delegate, you will need to make sure that person has the knowledge as well as the tools to complete that task. Finally, this experience has given us the opportunity to understand each team member's role and assessment process during a visit. It taught us to be respectful of their time and their skills. That concludes my presentation. If you have any questions, feel free to ask in the live session or email me at priji.varghese@utsouthwestern.edu. Thank you for your time.
Hi, my name is Abby Nicom. I'm a licensed clinical social worker from Orange County, California. I've been working as a social worker for just over 12 years. I received both my bachelor's and master's degrees from UCLA, graduating in 2008. Prior to my current role, I worked with individuals living with HIV/AIDS as well as adults diagnosed with severe and persistent mental illness. In 2018, I accepted the role as a pediatric social worker at the CF Center at CHOP. I am a member of our Patient Family Advisory Council and QI team, which includes ongoing participation in the CF Learning Network. In addition to working on the CF team, I work in the after cancer treatment survivorship and osteogenesis imperfecta clinics. I am very thankful for the opportunity to be here. There are no relationships to disclose related to this presentation. The objectives of the presentation are to describe the process of co-producing annual goals with patients and families, describe how to engage and facilitate multidisciplinary participation in goal discussion during a team clinic visit, and discuss how a multidisciplinary approach to co-producing goals can promote transition readiness and improve patient-centered care. Just a little bit of background. Our team has been wanting to establish a formalized transition program with center-wide policies, transition readiness assessment tools, and so forth, but it was put in the parking lot, so to speak, as we were heavily involved in the CF Learning Network and QI projects. However, I had already been having informal discussions about setting goals with patients regarding their CF care, overall health and well-being, and I thought goal setting could be an opportunity to at least get the transition program started, which is how this program came about. So our SMART aim was to increase the percentage of eligible patients with a co-produced annual goal from 0 to 50% by December 31st, 2020. We started September 1st, 2020. An eligible patient is defined as school-age, developmentally and cognitively able to participate. And this is done during quarterly and or annual visits, or essentially team visits. We have approximately 80 or so patients at our center up to age 20. And as you can see from the chart, just over 75% of them fall into the age range of being eligible to make goals. The overall process starts with me co-producing goals with patients. I introduce the concept of transition, the idea that it's not a point in time, but rather a process, and then the idea of setting goals around their health for the upcoming year. I engage the patient and family in discussion about their approach to managing CF cares, their family values, their health literacy. I partner with them throughout the process as they identify what's important to them. The goal setting is driven by the patient and family, but I do help ensure it's age appropriate and fine tune it to make it measurable if needed. The patient then receives a personalized goal handout. And the idea is that I would update the team at subsequent visits of the patient's goal in pre-clinic huddle, and then meet with the patient to review progress, see what I could do to help them meet their goal. Here's some sample goals. I will learn who's on my CF team and what they do. Age 8, to be able to put my vest on all by myself before my treatments. Age 5, I will learn how to order my medicine. Age 19, that's pretty common amongst our older ones. I will learn to ride my bike without training wheels. Age 6, we really encourage our patients to share any goals that they have, and some of them have added on a couple to their health-related ones. And this is an example here of a patient goal handout that we give once they make their goal. So the initial results, if you remember, we had said we wanted to get to 50% by December 31st. We were able to get to 92% of eligible patients had annual goals by December 31st. And then we got to 100% by March 23rd, 2021. And then by April 30th, 12 patients had met their initial goal. So not surprisingly, shortly after patients began returning 3 months later for that next visit after making their initial goal, it became very clear that I needed to find a way to get my team involved in helping patients meet their goal, as many of them were not really in my area of expertise. I had underestimated how quickly we would be able to co-produce all those goals, and I definitely underestimated the difficulty of some of the goals that the patients chose. While it was still my intention to continue to meet with each patient to follow up and provide whatever education and or support I could, it was evident that many required feedback or coaching from other disciplines. So we decided to implement a multidisciplinary approach, which required another QI project while still working on the goal setting. So the smart aim of this one was to increase the number of eligible visits in which the patient discussed their annual goal with more than one discipline from 0 to 50% by June 30th, 2021, when we started this mid-January. An eligible visit is defined as a team visit with a patient who has a goal or is eligible to co-produce a goal. The first step needed was to identify a way to ensure the entire team knew what the patient's goals were. With some team members being virtual, some being in clinic, this wasn't always an easy process. We had been using a live Microsoft Teams dashboard for pre-clinic huddle and throughout clinic, which had proven effective for sharing live information, keeping track of provider locations. The dashboard, which every team member has access to, had information like baseline FEV1s, PVP, types of visits, patient concerns, team concerns, and so forth. And this is what our CF nurse would read from during preclinic huddle. So we decided to add a separate column to the dashboard for annual goals so that the entire team could see each patient goals at all times. And you can see that it's outlined in black there. It was my job to update this prior to clinic. Once we did this, communicating patient goals became standard information that was read at each preclinic huddle. It proved to be an extremely effective way to communicate goals and still allowed for us to discuss throughout clinic. Next, we needed to determine how to facilitate the multidisciplinary participation. So now that everyone knows what the goals are, how do we get, assign people to the patients? For each eligible visit, we needed to determine which team members needed to meet with that patient to discuss their goal. We chose to use the dashboard again by having me write the team member names or disciplines directly in the column. So it was understood that not everyone was going to be able to fit this into their visit, but at least it was made clear that it was a request. Also, I would only write the names of team members that are already planning on meeting with that patient. You can see the before and after here. In the after, the disciplines are highlighted in yellow. So for the first one, it's learn the names of the meds in the order they go in: pharmacy, pulmonary, RT, and social work. This process allowed me to delegate responsibility and encouraged ownership from each discipline. Here's our process map. This was a really effective tool in helping everyone kind of see the steps and identify any kinks and really outline everyone's roles. The next and final thing we needed to do was to empower the team members to help patients meet their goals. Our team is extremely talented, and we're lucky to have many different specialties that I know some centers don't have. Our team was able to provide education, review techniques, teach skills, identify barriers, brainstorm solutions, motivate, celebrate successes. As far as the percentage of involvement in multidisciplinary goal discussions, our team just really stepped up to the plate. Pharmacy team was involved in 46% of those goal discussions. RT, 32%. The GIRD combo was 26%. Pulmonary providers was 24%. This does really kind of reflect the tendency for many of our patients to have goals related to pharmacy and their breathing treatments. It was just really kind of amazing to see. Even more amazing is our creative pharmacy team who makes these handouts for our patients. And this was in particular for a young monolingual Spanish-speaking boy and mom. And this little guy likes Spider-Man and Sonic and wanted to learn the names of his medication. And they just kind of went all out. Our pharmacy team also has made these handouts to help patients learn the purpose of their medication, and they've made it in 3 different stages, 3 different complexities, I should say, from basic to more complex. And this has gotten really good feedback from our patients. So results, 100% of our eligible patients do have co-produced goals. 60% as of August 31st of our patients have met their initial goal. 17.7% of our patients have met 2 goals. And as of today, when I'm recording this, 65% have met their initial goals and 23% have met 2 goals. So we are continuing to make steady progress. So our SMART aim was to increase the percentage of eligible visits in which a patient's goal was discussed with more than one discipline from 0 to 50% by June 30th. So we did that. It was 64.8 by the beginning of July 2021, as you can see in the chart. Then by September 1st, we were at 70.9% of visits involving multidisciplinary goal discussion. And that was 100 out of 141 visits. And again, we continue to see a steady increase. Something that I did start to measure and notice, but we weren't intentionally trying for, was visits that included more than 2 providers. And out of those 100 multidisciplinary visits, 36% of those included more than 2 providers. Sounds like a pretty comprehensive visit. So patient, family, and team feedback from a team member. When I asked him if he needed refills for his GI meds, he quickly answered very clearly with a full sentence, "I ordered my meds yesterday and I'll pick them up today." He seemed empowered by the fact that he accomplished his goal. "Thanks for the handout. It helps me learn more too. We are very thankful." From a parent. "The next time I see you, I will have a new goal. Keep asking me about my goals." From a 7-year-old boy. That guy has like 4 goals. So impact on transition readiness. Multiple team members are facilitating discussion regarding self-advocacy, shared responsibility, health literacy. This isn't something that is just primarily what I'm doing. And it's absolutely something that stuck out to me because, at least based on my observations, it seems like different team members are taking ownership of how their role in the team can really make a positive impact upon the patient. And so not only are we helping the patients in terms of their transition readiness, but the concept of transition readiness is being embraced more by our team. This project has increased patient engagement starting at a young age, and it's encouraging us to speak directly to patients, which I think we were doing a good job of before, but this is kind of creating that expectation and creating that space to do that. And our patients are receiving personalized education rather than just something based on age or expectation. Impact on patient-centered care. So this isn't adding any significant extra time onto their visit. This is driven by the patients and families. So this is what's important to the patient, what they want to work on. It's enhancing our understanding of them. We get to know what their strengths are, what their interests are, what areas they have for growth. It's absolutely increasing our interdisciplinary communication. Because of this project, I've partnered much more with each of my team members than ever before, mostly because we're discussing the goals. For example, if a patient wants to work on learning to do a treatment independently, but there are interfamily dynamics that are impacting the patient's ability to succeed, the respiratory therapist and I consult ahead of time to figure out the best way we can help. The more our team talks to each other, the better care we provide. And it's been driven by their goals. Yeah, of course, it gives us lots of opportunities to celebrate our patients. So next steps, I'd like to focus on a way to standardize documentation of patient goals in the chart. I'd like to look at addressing some of the barriers, like if we have providers that are not primarily CF providers, what happens if we don't have a huddle, working on some of those education handouts, and exploring ways to measure the impact on transition readiness and team communication. Okay, thank you very much.
Hello, my name is Sharon Mcnamara. I'm a research manager and member of the QI team at Seattle Children's Hospital in Seattle, Washington. I'm going to be talking with you about pre-clinic review and team communication during transitions in CF clinic care, quality improvement project. I would like to thank the moderators for the invitation to present at this NACFC workshop. There are no relationships to disclose related to this presentation. We all know that team preclinical review is an important part of care for people with CF. Identification and communication of patient care needs is crucial to improving quality care. This is typically achieved through preclinical review of each patient by each team member, which is then shared, allowing for coordination and comprehensive and efficient care. Meeting as a team in person prior to clinic has been an ongoing challenge for Seattle Children's due to variable schedules and other commitments of CF team members. Prior to March 2020, Seattle Children's CF care team members individually completed preclinical review. Team members sent email to a CF clinic medical assistant to indicate if the patient was needed to be seen and prioritized using a green, yellow, red system. The MA compiled all team member responses into a single document before each clinic and shared with the team by email. The document was referenced during clinic to facilitate patient care and clinic flow. Here is an example of what that schedule looked like. It was pretty simple. Patients were listed on the y-axis with the disciplines across the x-axis, and you can see who wanted to see the patients and how they had prioritized them. Here's red and here's yellow. We don't see any green on here. And then COVID came. The pandemic had a huge impact on us all. It necessitated rapid changes in clinical care for care teams and families. Telehealth primarily began at Seattle Children's in mid-March of 2020. There was limited team interaction with patients and families, as well as with one another. We weren't able to share what our priorities were or what our plans for care would be. We were fortunate in April 2020 to begin some asynchronous telehealth visits. Initially, these were conducted by the MD with follow-up as needed by team members. There were definite gaps as well as duplication of efforts during these times. We had limited reopening of in-person visits beginning in June of 2020. There were, however, ongoing restrictions to team member presence during those visits due to both institutional and personal preferences. But we looked at this as an opportunity for improvement. The QI team aimed to improve the process for preclinical review and communication among team members and care providers, which could be sustainable throughout transitions in clinic care. As Albert Einstein reminds us, in the middle of difficulty can lie opportunity. And we took this difficulty to move forward to improve our preclinical review. To begin with, we developed a key driver diagram. This was focused on telehealth during the pandemic, and we delineated drivers to co-produce CF care. Inter-team communication was identified as a primary driver, as seen here on the key driver diagram. One intervention was identified as the rainbow sheet, and that is going to be the focus of my talk going forward here. The QI team used PDSA cycles to revise and streamline preclinical review and team communication processes. We started with the aim of creating a multidisciplinary clinic review spreadsheet, and I will be talking about some of these steps as we move forward. What do we do to improve the process? We asked team members initially to send their independent preclinical review to the QI leader to include things that they wanted to talk with the patients about, things that they felt were important related to clinical care. The QI coordinator then collated this information into a single spreadsheet, which was sent to providers and the clinic team. During this early phase, several weekly reminders were sent to the clinic team by the QI leader and the clinic coordinator reminding them to send in their pre-clinic reviews. There was a lot of nudging being done. Due to the workload of this process, we transitioned and we decided to send a calendar invite to team members. This was initiated in lieu of the weekly reminders with the aim to facilitate timely completion so that that form could be collated to be sent to the providers. We also clarified expectations and weekly goals for completion. Goals were set to be 3 working days prior to the upcoming clinic. At Seattle Children's, we have clinic days on every Tuesday morning, every other Friday, and 1 Wednesday a month at an outlying clinic site. To improve further, team members then requested access to a spreadsheet so that they could self-populate their pre-clinic reviews. This resulted in a process adaptation to use an online shared fillable form, which came to be termed the Rainbow Sheet. And I'm going to show you an example of the Rainbow Sheet, and I think you'll understand how it got to have that name. The form was tested by the QI team and revised to add an indicator of prioritization as to who wanted to see the patient, as well as team member availability during the clinic. Were people in clinic in the conference room? Were they in their offices, or were they off-site still working remotely? There was quite a bit of variation during this transition time. Team members were educated about the revised process and transitioned themselves to completing the shared fillable form independently quite rapidly. So here is an example of the Rainbow Sheet, which has been de-identified. You can see along the x-axis that we have the patient names listed, we have their ages, we have the time of the appointment. This is a provider who is going to be seeing these 3 patients, and this is an abbreviated Rainbow Sheet. Typically, we would have 10 to 12 patients listed across this axis to include things such as PFTs, maybe they're going to see the endocrine doctor or GI. And here along the y-axis are the different team members: nursing, nutrition, pharmacy, research, and so on. And so you can see it can be expanded to add other things, such as sometimes we have child life in clinic. Each discipline can go into the sheet, which is on a shared drive, to complete their pre-clinic review. And some are quite extensive and others are abbreviated. You can also see the prioritization. Here is somebody who nutrition says is red. They really want to see them. Here is somebody that they say is green. They don't feel that they need to see them at that visit, but if there's time, maybe they'll pop in to follow up on the last clinic visit. Here is a patient who is yellow. Pharmacy would like to see them, but it's not absolutely essential. So this helps to drive our visits and to make clinic flow more efficient, which was also a goal of ours at this time. So what were the results? We found that team members' completion of the Rainbow Sheet was variable when initially introduced. We found that about a half to 2/3 of team members were able to complete it within the time frame that was required or being requested. We found that barriers included people working part-time, and maybe they were forgetting, even with the weekly reminders from the QI leader. We also found that the calendar invite to complete pre-clinic review, which could be set up as a repeating event with a link to the shared form, resulted in improvement in team satisfaction with this new process. Initially, compilation of the individual pre-clinic review required a significant amount of QI time weekly. Transition to the online shared fillable form increased efficiency and accuracy. It allows for easy updates as well as visibility by all team members. With transition to the fillable form, which is populated and viewable by all team members, weekly completion increased to 83 to 100%. And this rate of completion has been sustained over a long period of time. We found that providers were not wanting to open an email link to the Rainbow Sheet, which resulted in another process change with the QI leader sending an email, which includes a screenshot of the Rainbow Sheet with a provider's patients for a given clinic. The majority of providers, about 2/3, indicate that the Rainbow Sheet is a useful format for reference and communication with the CF team members, recognizing what the priorities are for each team member in seeing patients. So what are our conclusions? We felt that team communication related to patient care improved with this expanded and visible pre-review process, which can be used in a range of clinic situations, ranging from telehealth to asynchronous visits to in-person clinic visits. Completion of the pre-clinic review Rainbow Sheet by CF team members has been adopted as a routine practice for us and has sustained with return to in-person visits and ongoing telehealth. Provider access and use improved with orientation to the information and format. And where do we hope to go? Identification of team member location and coordination for asynchronous telehealth visits continues to evolve as we continue to have families who don't want to come into clinic in person 4 times a year and have really enjoyed having the opportunity to have telehealth. We are looking to delineate the scope of preclinic review by discipline. This is an ongoing process, and our future PDSAs aim to improve efficiency and relevance of information to optimize patient care and to integrate our goals for patient care with the patient and family goals. I'd like to acknowledge the Seattle Children's QI team members, our CF Clinic Director, Ron Gibson, and the clinic and research team members who participated in this initiative and have been very supportive and have given us lots of feedback and continue to help us to improve this process. I'd also like to acknowledge CFF funding for our CF Center and the CF LN Learning Network. And I'd like to invite any of you who are interested in having our Rainbow Sheet template to contact me here at Sharon Mcnamara at seattlechildrens.org. Thank you very much.
Good afternoon. My name is David Miller. I'm one of the adult providers at the Cystic Fibrosis program at the University of Arizona in Tucson, Arizona. Today, I'm going to be talking to you about a rethinking of the cystic fibrosis care team, a novel hybrid clinic structure that promotes interdisciplinary care and improves understanding of each team member roles. I have no financial relationships to disclose related to this presentation. So today, we're going to talk about first defining multidisciplinary and interdisciplinary models of care, because they're often terms that are used interchangeably, but they actually mean quite different things. We're also going to describe the story of how our telehealth model that we were forced into, in some sense, has informed our current in-person hybrid clinic model. We'll then go to some of the data we collected from our own team members of the benefits of this model, and then recent sort of preliminary data that we've been collecting as feedback from our patients regarding the hybrid model. So first, starting with the concept of multidisciplinary care, this is often a term used for chronic disease management and often is something that's used as a term to describe a CF care team. But generally, it's when you get providers from multiple disciplines that approach care from their own perspective. So this draws on knowledge from each of our colleagues and from each different discipline. However, the final sort of plan of care from each person remains within the boundaries of each individual's. Whereas interdisciplinary care, providers from multiple disciplines join simultaneously in a single consultation to jointly form a plan of care. And I think this is what we all, as providers of people taking care of people with cystic fibrosis, strive for. But you'll find that you don't always meet it. But the nice thing about interdisciplinary care is the simultaneous nature where you can analyze, synthesize, and harmonize between disciplines in order to coordinate and create a coherent plan. And we'll sort of describe how our model gets at this. So the story of our clinic's pivot to interdisciplinary care was actually an accident. So when COVID-19 started and we were all forced to transition to telehealth, we were limited in what our institution provided us with. So Zoom, which many care teams used and is an excellent platform and we use for meetings, was not something that we were allowed to use for direct patient care. And we as a care team were actually quite jealous when we heard stories of other care centers using Zoom and having breakout rooms so you could meet with your dietitian, you could meet with your pharmacist, whatever person was needed individually, and kind of continue the clinic model that we all knew and were accustomed to prior to COVID. We, though, were limited to Microsoft Teams, and I'm not going to say anything positive or negative about that platform right now initially. And then our institution pivoted to eVisit. What was unique, though, to both of these platforms is the fact that the visits had to take place with all providers present simultaneously. We did not have the option of breakout rooms. So our patient would be there in this sort of classic form that you've seen. Our patient would be that video in the center, and then all of us would be around staring at them talking. And at first, we thought this was going to be an actually quite awkward way to deliver care, but it actually then continued to develop into what we use today, and I will explain this further. So even then, after we sort of backing off from telehealth, though we still use this relatively frequently, when we started to return to in-person visits, we actually continued this hybrid visit style. So you may say, how do we do that? So what we do is we have excellent pre-visit planning where we can often predict the individual needs of our patients in advance of their actual in-person clinic visit. So what we have is we have the MD for every visit, but then we targetedly choose 1 to 2 of our team members to join the physician in the room. We then take a computer with a video link that links back to the remaining team members who are sitting in the same clinic space, but in a conference room. And then we continue to conduct the visit as a full group simultaneously with the patient. However, the fact that everyone's present in the clinic, you still do have the option when needed to revert back to individual meetings with the patient. So an example of what happens in this type of clinic visit is sort of, one of the classic things that we often ask for are GI issues. And in particular, if a patient has pancreatic insufficiency, we get at how are things going in regards to that. And with the style of visit, oftentimes we know in advance, this is a patient that often has issues with their enzymes. So we can target that so that the MD and the dietitian are in the room. But we also have the whole gamut of the rest of our providers listening in. They hear the story simultaneously. They can ask questions in real time. The plan is made with everyone's input simultaneously and set up when we go. So for example, patient needs to increase their enzymes because they're having frequent loose stools. This may be elicited by the physician. Maybe it actually doesn't have to do with the enzymes, and the dietitian is right there and clarifies a dietary history. Or in real time, we realize it's actually an issue the patient's just forgetting to take the enzymes. So our psychologist will chime in and give real-time feedback to the patient as to how they can potentially have better adherence or better remember to take their enzymes or the appropriate amount. And also listening in is our nurse navigator, who in real time puts this plan in the patient's after visit summary for them to leave with. So this is a lot and a kind of a big flipped sort of model of a clinic visit, but we've actually, as a team, learned a lot. So we actually surveyed everyone from both the adult and pediatric teams. And I will tell you that both of our groups now are actually enacting these hybrid visits during in-person visits. And we surveyed each member of both the adult and pediatric teams. And this is the result of looking, the yellow is pre-interdisciplinary understanding. So pre-COVID, simultaneous visits, and the red is post-interdisciplinary understanding. So this would be post how we have this hybrid clinic model. And you'll see that with every single specialty in our clinic, after implementing this hybrid model, we had a better understanding of what one another did. The exceptions here are the physician. I guess everyone supposedly knows what physicians do, and also the dietitian, but there was upwards of a point improvement in understanding of what other people did. And that also allows us to then provide better care because we understand better what each of us are doing to take care of the patient. So some of the comments that we got back with this survey was that this model significantly improved efficiency amongst the team. So there was less overlap in questioning. We all hear the answers and the questions at the same time. There was less repetition. So if I was dealing with an active issue with that patient's enzymes, the dietitian, the pharmacist, the nutritionist, everyone didn't have to come in after me and ask the same questions to get at the same answer. Similarly, people say this removed redundancy for patients. And it also allowed amongst our team more succinct communication. We solved an issue in the order of minutes and closed the loop versus solving an issue with multiple people, meeting afterwards, rediscussing afterwards. Everything happens in real time. There were also a decent amount of comments on the survey of the adult and pediatric teams that there was better understanding. And again, that like the improvement in Likert scales that I just showed is sort of reflected by this, but one person noted there was a greater respect for one another and more reliance on one another to improve patient outcomes. There's also an ability to easily engage each discipline in real time when patient issues arise, and that's kind of what I'm getting at. We've also recently started surveying our patients because returning to this hybrid visit in person, I personally, as one of their providers, was very concerned that this would lead to sort of lack of personable visits or awkwardness. And interestingly, from the limited data we have back, patient response has been quite impressive. And one sort of side note, we actually tried in one clinic returning to the old model where everyone saw each patient individually, and then we re-met at a post-visit huddle to sort of come up with the plan. We all hated it. We were miserable. And the thing that actually emerged that was most unique is we weren't having as much fun as we were with this new style of visit. But looking at the patient's perspective, because in the end, that's what really matters. We've surveyed so far 17 of our patients. This is an ongoing survey. And now, obviously, at the time of this presentation, we have a lot more data collected, and I hope to be able to update you. But we surveyed 17 patients immediately at the end of their visit. And 13 of the 17 said that they preferred the hybrid style visit. And by hybrid, they said physician plus 1 to 2 other team members joining in the visit that day. Now, when you break down to actually what the 4 of 17 were saying, only 1 actually said they wanted to return to the prior style. One of the people actually said they wanted all telehealth because they didn't want to drive the 3 hours to our center. We have a huge catchment area in Tucson for our CF program. Another person said they preferred the efficiency of this visit, but felt, again, like I said, it was a little less personable, but we try to take that all into account. But what was very unique, and what the results of this survey has been showing, is that 100% of the patients, so all 17, report that they were very satisfied. So that was the highest level on the survey with this style of visit. 100% of the patients reported this was a very efficient use of my time. And 100%, including those 4 that said they wish to go back to the other style, reported that all of their needs were met during that clinic visit. The other thing I will say personally that this hybrid visit helps with is when we're pivoting between in-person and virtual visits in the same clinic day, having that whole team available both for in-person and virtually is very useful for both myself and also the patients. So I'll stop there. Obviously, I would like to thank all the members of the adult and pediatric team for tolerating the survey to review all of this and for being such a great team to work with. One person I'd like to point out in particular is Dr. Bowen. She's our psychologist with the team, and she's also sort of our survey guru and collects data like no other. And a perfect example of how this hybrid visit works is she recently had both of her shoulders replaced and actually came to clinic virtually the day after because our platform allowed for it. So at that point, I will stop and thank you all and look forward to questions after the presentation.
Resiliency training for maintaining or improving the cystic fibrosis staff's mental health. by Phoebe Long, Krista Gregory, and Cheyenne Pye from Dell Children's Medical Center in Austin, Texas. I have no relationships to disclose related to this presentation. Healthcare professionals have experienced higher rates of emotional distress during the COVID-19 pandemic, and team dynamics both influence and are influenced by individual well-being. So tools that build self-awareness and emotion regulation and opportunities to process experiences and team discussions may protect healthcare professionals from mental distress and improve team outcomes such as psychological safety. The objective of this project was to maintain or improve the cystic fibrosis team's psychological well-being, and that includes emotional awareness and regulation, professional quality of life, mental health, psychological safety, and quality of care during the COVID-19 pandemic. In 2020, the Specialty Care Center's pediatric cystic fibrosis team at Dell Children's received resiliency training twice a month during their team meetings from the Center for Resiliency. The trainings were 15 to 30 minutes and offered short, practical tools the team could use to regulate difficult emotions, connect to their core values, and cultivate compassion for themselves and those with whom they work. We measured a number of psychological variables to understand if any changes would occur after attending training. 14 members of the cystic fibrosis care team staff completed self-report surveys twice before the intervention in January 2020, before the pandemic, and then during the pandemic in June of 2020, and then once after the intervention in March of 2021. Here are some examples of the short practical tools we taught the cystic fibrosis team that they could use in the moment on the job to regulate difficult emotions. So I'll share one of them with you right now. It's called Finding Your Anchor. And whenever you feel overloaded or experiencing high stress, you can find your anchor to bring your awareness to the present moment. Your anchor can be anything. It can be the soles of your feet, the breath, sound, anything you experience with one of your five senses. And we'll work with the soles of our feet for now. So you can stand up for this practice if you're able to. And we'll just take a breath as we start. And begin by feeling the soles of your feet on the floor. To do this, you can rock forward and then back. You can rock side to side. Just noticing the way the soles of your feet feel on the floor. You might try making circles with your knees, moving in one direction and then the other, and just feeling the changing sensations in the soles of your feet as you move. When you notice your mind wandering, just feel the soles of your feet again. That's perfectly normal. You might try walking slowly forward and then backward. Again, just noticing how the sensations in the soles of your feet change. So what we're doing is nothing magical. You're just noticing your feet, focusing on something else besides what's going on in your head, being where our feet are with our attention. You can bring your attention all the way down from your head and into the soles of your feet. The furthest you can get from your head and your body and what's going on in your head is the bottom of your feet. And then just taking another deep breath
coming back into stillness. And know that the next time you feel overloaded, overwhelmed, or a little anxious, you can find your anchor, whether it's your feet, your breath, or another sensation. So just taking a moment to notice how you feel after this practice. Is there anything that feels different than from before you started? And know that your feet are always with you, so you can do this practice anytime, anywhere. You can do it as you're walking down the hallway from one meeting to another, or walking around from one side of a patient's bed to the other side. You can do this practice when you're having a difficult conversation with a coworker or a patient. And so we taught the cystic fibrosis team a number of practices just like that, practices you can use in the moment on the job to regulate anxiety, depression, stress. And then we measured various psychological outcomes, both before the intervention and after the intervention was over, to see if anything changed. So we measured self-compassion, we measured mindfulness, compassion to others, professional quality of life, which includes compassion, satisfaction, burnout, and secondary traumatic stress. We also looked at depression, anxiety, and stress, psychological safety, and quality of care provided to patients. So you can see from this chart that on the outcomes that we would expect to change or we would hope to increase, that no differences were really observed. You can see the mean scores of the group stayed relatively similar throughout the 3 time points. And then on measures that we would hope to see decrease, things like burnout, secondary traumatic stress, depression, anxiety, and stress, scores also stayed relatively similar. There were no statistically significant differences between time points, although you can see from the chart that depression and stress both increased among the group during the pandemic, so between June of 2020 and March of 2021. And that is a consistent trend among healthcare professionals experiencing heightened depression and stress during the pandemic. So in conclusion, there were no statistically significant changes in the outcomes we measured. We did see non-significant increases in depression and stress, which occurred during the pandemic year. It's possible resiliency training helped keep individual and team well-being stable for cystic fibrosis team members throughout the pandemic, but it would be best in future studies to utilize a control group so we could really understand the impact of the intervention above and beyond the impact of the pandemic on these well-being variables. It would also be really helpful to increase our sample size and potentially provide in-person training as well. So to contact me, this is my information. You can call me at the number listed or email me at phoebe.long@ascension.org. Thank you so much.
Hi, everyone. Welcome back. This is our last and final session of NACFC 2021. Yay, we made it. Thank you guys for hanging in there with us and navigating through all the new platforms. Thank you guys, audience, for sending in so many wonderful questions. And we're going to kind of do this as a round robin style format. So we will start with a general question to the panel, but before that, I just want to say thank you to all the speakers. We have a few of us who are making our presentation debut today, so congrats. You guys all did a really great job. We have Sharon Mcnamara from Seattle, Phoebe Long from Austin, Abby Nicom from Orange County, and Dr. David Miller from Tucson, Arizona, and Priji with Dallas team, and Cheyenne is over there manning the chat. All right, team, so we will start with a general question. Any techniques for promoting teamwork while managing multiple roles in your day-to-day work life? Techniques to promote teamwork if you are having multiple roles that you play. And I guess I'll start. I think it's very important identifying your primary job duties when you come to work. So as an RT, these are the job duties I do, but also then to have secondary job duties that you're able to do to help your team members. And then make that visible to everyone, have a conversation as a team to know that, hey, I can do this if you're busy doing that in clinic. So identifying primary duties as well as secondary duties will be really helpful for your team members to know who they can reach out to if you're struggling in clinic or have multiple things going on at the same time. Sharon?
I think one of the things that's really important is to not be afraid to offer help, just kind of following up with what you said, not to feel like everybody's in a silo and not to step outside that boundary, because, you know, as we know more and more about what each person does, then we can kind of step in. And I think the other thing that has been alluded to is just the turnover in teams during the pandemic, and kind of how to bring new people into the team, and making sure that they're welcomed and also oriented to what CF care is.
Absolutely. Phoebe?
Yeah, I mean, I think what we did with resiliency training for Cheyenne's team at Dell was to really like provide a space for people to talk about kind of the emotional dimensions of the work that we do, rather than only focusing on clinical. That was really the space that we offered for folks. And then also to offer kind of these short practical tools we could use when we're starting to feel like stressed or anxious, that we could use to kind of regulate our difficult emotions during the workday. And it's super cool that I think teams learn those things together so that they're not just practicing wellness tools in isolation, but can really reinforce those skills for each other.
Thanks, Phoebe. Abby?
Yeah, I think learning each other's personality styles is really important, especially when you're on a team, and because there's lots of different approaches that we all have. And I also think making sure we all understand what we expect of each other, having that open communication, especially when we're balancing multiple hats.
Absolutely. And Dr. Miller?
I would say the biggest thing, even piggybacking off of what I was saying in the talk, is that understand what each other do and how we do it. So what Abby just said, understanding one another's personalities, because we all do things differently, but then understanding what we do for our patients individually. And personally, like, I just need to shut up sometimes and listen to other people. So not talking and listening to what others have to say. But
Yes, perfect. No, I totally agree. Listening to one another and knowing what each other's strengths are and what can, frustrate somebody else is really key, because when we're working together as a team, I mean, our patients see it and they'll know if their team is not cohesive. So thank you guys for sharing those techniques. So now I'm going to go into individual questions for your presentations. And I think we will start with Abby. There was a lot of requests to Abby on the team's dashboard. If you could give us some insight into what that looks like and that process of creating that dashboard.
Yeah, so I'm lucky to have this amazing clinic coordinator, Myvi, that she created this Excel spreadsheet and then imported it into Microsoft Teams, which is what we use. during clinic. And the Excel, or we call it our dashboard, and it has a list of our patients that's done ahead of time. And the dashboard includes clinical information that's pertinent to the visit. It includes all of the team members' names, and ahead of time, we indicate which patients we're going to see. It includes information like baseline FEV1, what the pre-visit planning was. I'm probably going to say this wrong, but the FIES and SIS, again, it's probably, I don't know if I said that right. Right. And then it also included, what we added was the annual goal information. And the cool thing about this was that we were able to edit it live and all see it during clinic. So we knew which providers were during clinic, who was in what room, and it was just really great, so that even if we had providers that were virtual or some were in clinic, we always were able to communicate, and we also could use the chat feature as well.
Perfect. Now, Abby, in terms of the goals with the children, did you guys have general age-appropriate goal suggestions for families and patients?
So if the goals were created kind of in the context of transition discussion, so I would review what transition was and talk about, this is a process over time, the process of moving from a pediatric-centered, care to adult-centered, it's adult-focused. And then we would talk about milestones and different stages of life, and we would talk about what examples of milestones, but we'd also say, patients with CF also need to make health-related milestones. So I would ask them about what they do at home, what they know, what their involvement in their care is. And if they were able to come up with something that they want to work on in the next year, great, I want to learn this, or I don't know the names of a medication, so I want to learn that. If they weren't able to come up with something on their own, or if their parents or caregivers weren't able to, then I would maybe say, well, I know some of our other kids in our clinics are learning this. Would you like to learn that? Or do you know the names of the providers? I would give them some suggestions, but ultimately it would be up to them. And then they could add on stuff, other things like learning to ride a bike or learning to swim. We would always encourage that, but we always had a health related goal.
Perfect. And how many goals were they allowed to have?
Can have as many goals as they want, but wanted to focus on one health related. And, if they wanted to add something like one kid wants to score his first hockey goal, but he also wants to learn how to huff cough consistently. Mm-hmm. So perfect. We'll celebrate both.
Oh, yes, absolutely. Now we're going to move on to Sharon and the rainbow sheet. There's been a lot of talk about the rainbow sheet, Sharon. One question for you. Did the rainbow sheet provide space to list priorities of who the patients wanted to see?
That is a great question, and one which our clinical nurse specialist will be delighted to hear. It does not at this point. We have, and it will be great to incorporate that, which is the nice thing about the rainbow sheet, is that it is expandable and can be changed as we identify new needs. We have recently started using, we switched to Epic about a year ago, and we have in the last 4 to 5 months started using a day of clinic form, which was built into Epic, and are working on a project around that to get families to complete that. And it would be nice then to take those responses and incorporate them into the day of clinic form, so that there's just one place to look, for team members to see. And then that may, could also then potentially indicate if they need to see RT and RT wasn't planning to see them that day, for example. So not at this point, but yes, a future goal. Mm-hmm.
Wonderful. Now, another question, Sharon, is the rainbow sheet on a shared Excel or OneDrive document that's easy to access for everyone?
Yes, great question. So it is now. So initially it was not. And, you kind of make these baby steps as you go along and start a new process. So initially it was kind of under the jurisdiction of our quality improvement leader. But one of our, actually our pharmacist really pushed us to put it on a shared drive. And we did. And actually the QI team first tested it to see, can we really all fill it in at once? And we could. And so then we launched it out to the whole team, and they really readily jumped in. So it's on a SharePoint, and it's an Excel spreadsheet that has permission set. So it's kind of like a Google sheet, a Google document. People can fill it in at the same time. It can get updated. And yeah, so it's been great in that way. And I don't think anybody can erase anything permanently.
Well, that's good. Are those sheets ever printed for like in-person use?
Yeah, so they are being used different ways. One of our providers loves to have his printed out, and he does his clinic prep several days before he has clinic. And so he does print them out. And so that's really encouraged people to fill it out in that deadline ahead of times. I saw recently, I saw our dietitian completely flip it on its side and cut and paste things into a schedule for herself. So she just had the information and yeah, so people are kind of making it their own and printing it out. You know, we really want to have one of those big neon dashboards in clinic with the rainbow sheet on, but haven't gotten there yet.
Yes, I think that's a work in progress in our center as well. Moving on, these questions, the next few are going to be for David. David, there's a lot of chatter about the hybrid visit. So if you don't mind, there was one question. Let's see. How many providers do you have in clinic at once? Many centers have more than one. So how does that work?
So we are, in that sense, for this style of visit, we're at an advantage in that there's only one physician per clinic session. So it is sort of processing through with the whole team. And it's the same in our pediatric clinic as well, that it's one physician provider in clinic.
Got it. That makes sense. That is why you're able to do a hybrid visit.
Yeah.
With multiple providers, it's really hard. Another question for you, Dr. Miller. What were the rates of mental health screens reviewed with patients in this model? Any issues at all with mental health care to be discussed in this model?
So a couple of things, and that's something that I think we as a team worried about. So as far as rates of screening, it's 100%. We're still doing all the surveys. We even were participating in the health-related quality of life with through the CFLN, and in association with that, we had tagged on sort of mental health screening and depression screening to that survey. So the patients all got that. We would try to get that in advance of clinic so that we could address it in our pre-visit and say, oh, there's an issue here. So that was, I would say we did actually screen everyone. The second thing we would do is when we entered the room, initially we would ask for permission from the patient. Is it okay if we bring the whole team in at once? Is there anything that you want to talk about individually with me or with someone else? So they had that opportunity. But what actually emerged was, again, surprised me. And I can think of 3 or 4 specific examples where a very sensitive topic came up, and I would offer the patient the option, do you want to talk about this with me or someone else alone? And they said, oh no, you're my whole team. I can have everyone hear it from really significant social or mental health issues. So I was caught off guard by that, but it seems like it really is not an issue so far. And the last thing we did to try to target it, because I saw there was a question related to sort of how does the social work part of the team elicit that. Our social worker actually was probably more resistant than all of us to this switch, to this style. And I say that in a good way. But what we actually started doing even with her was going to give the patient the after visit summary at the end of the visit. And so she would get a chance, if needed, to sort of address that with the patient. So it's still a work in progress, but it seems to be not as big of an issue for those types of things as I thought it would have been.
Yes. And I think, what your project and the one that we did in Dallas, pretty similar in the fact that we were tag teaming as we were going into the room. So in our center over the telehealth visit, when we had social workers in with us, again, just as you said, David, we'd, as a provider, we'd ask permission. Hey, is it okay for all of us to be here? And if there was something that the patient wanted to discuss in private with either the psychologist or the social worker, then that would have been a phone call to the patient after that visit was done. And so that way, nobody else was privy to any of that information. And, if that needed to be shared with the team, our social workers and psychologists would do so. But I think, I was a little hesitant to have myself be on camera while the social worker was there asking these questions. So sometimes I would say, hey, my questions with you are over. So I'm just going to go off camera and have you just, one-on-one talk with the social worker. And I think our patients and parents really appreciated that. But overall, I know there was a few questions about patient satisfaction survey with the telehealth tag teams. That is a future step for us, next step for us to survey both patients and providers. But overall, just verbally, I think our patients really appreciated all of us seeing them together at the same time. It cut down on them having to repeat, the same answers or anything like that. So the feedback from both the team as well as our patients have been very positive in having a visit together with the whole team. Virtually, it was easier. In clinic, it's a challenge because our rooms are very small and it's hard to get all of us in, but we continue to try to tag team at least 2-3 team members in our in-person visits as well currently.
Yeah, no, we've enjoyed it, so it's been great.
Perfect. Now, Sharon and David, have you guys done like a time study at all to see if this is cut down on your total time in clinic?
I can go first. Yes. So that was one of my biggest issues with adults who on modulators are doing incredibly well for the most part. It's like sometimes we're having 4 visits a year, kind of like, what are we talking about today health-wise? They're really excelling. So I felt guilty. Pre-COVID, we were a 2 to 3 hour clinic visit for many of these patients. Now, with this current model, we are about 40 to 45 minutes total time in office, including swabs and a PFT. So that was a big, I'm into efficiency. So that was a big thing that I was interested in coming into the clinic. So we've significantly cut down. I will admit though, you every once in a while kind of hit a doozy and it throws everything out of sync and can mess up the entire clinic, but that's how clinics are. So
yes. Wow, 45 minutes. That's amazing.
Yeah. Impressive.
Sharon, what about you?
I have a question for David, actually. Do you think that's because they are healthier and so you're not having to address so much?
I do think that's a part of it. It's also a part of, our RT has known some of these, has changed some of these patients' diapers. So she has known them their entire life and she has trained them well in what they need to do. So one comment was, an RT mentioned I spend 20 or 30 minutes every visit discussing cleaning their equipment. There are certain patients that need that every visit, and we will target those patients to do that. But for the most part, they don't need that. And so we know that. And that also has allowed us to, I feel like this has pretty seamlessly gone into place.
Yeah. I can talk a little bit about our clinic flow. So pre-pandemic, our clinic flow was terrible. And we actually had the transplant team coming in after us in clinic. So all of a sudden we had to be out of the room. So we actually did a big clinic flow project, kind of looking at time and so on. And we had gotten our clinic visits down to under 2 hours, which for us was a big accomplishment. We're a pediatric center, so, different situation there. But that was what initially instigated sending the MA the priorities for the team, was so that we could then, the MA could then decide, okay, this person, 5 people want to see this person today. You can't all see them. Which 3 is most important? And so that was kind of the beginning of our clinic flow. But I was just recently thinking, we need to look at our clinic flow timing again, because I think one of the things that happened with people coming back into clinic in person was that all of a sudden everybody wanted to see them again because they hadn't seen them in person for 6 or 8 months. So we haven't looked at it, and we need to do that. I think that would be a good follow-up project to see where we are. So.
Perfect. Now, we did a time study a couple of years ago, and we were well over 2 hours for our visit. And so we've done many things to sort of cut that down. And our goal right now is 164 out the door and 164.
Oh.
So it's still, like you said, a work in progress. Now I'm going to move on to Phoebe. Thank you, Phoebe, for doing that relaxation method with us. I felt so relaxed before we started. I really think you should do some meditation classes or record something for the whole CFF community. But if you wanted to talk a little bit about working with the clinical team, I know you don't work in their clinic, do you? Or you just yeah, so how is it coming in as an outsider coming into a CF center and kind of teaching about such an important training session?
Yes, I'd love for Sharon and to jump in whenever you want. But our Center for Resiliency is embedded in Dell Children's Center as a hospital. And so we've worked previously with Shannon's team, and we already had pretty good relationships with the team before doing this resiliency training. We've taken them on retreats and have done other kind of resiliency programs with them. It was nice because when we worked with them on Zoom, even though often we couldn't see each other's faces, we had this prior relationship developed, which I'm not sure it would have worked as well otherwise. But yeah, it's been a real pleasure to come in and learn from your team about kind of what your unique needs are. I would say you're a very highly functioning team. One of the more like well teams that we work with in general. So yeah, it was great. I had a lot of fun.
I'll pipe in a little bit.
Yeah.
I think our relationship with Phoebe in the very beginning when we first started it was years ago. I don't know if we were emotionally as healthy then, not knowing what we're doing. But by working with them, and I have to say we are very blessed to have this program for our institution for our team to have access to. We have built the skills, which acts as a really good baseline when we went into COVID pandemic, so that we were able to see the effects of COVID on the team because we had such a good baseline. And then to have the class repeated during COVID, because as we all experienced, the extreme change and rapid change was definitely affecting the team. So we were able to test that, I would say right after COVID pandemic started, 6 months later, and then a year later, to see the results for the team. So it was a very eye-opening for us, and also to learn how resilient our team was even through all the challenges. So it was a really good blessing.
Good. And are you guys planning to continue this training?
Most likely, but not at this moment, because I feel like we're pretty well gelled. Usually we don't do these trainings like often. We probably would gap it about every 3 to 5 years, just so that it's like a refresher. And also we do it if there's a whole lot of new team members that hasn't been through it. Also, our institution have these resiliency classes that we can attend on our own if we need it in addition. So we don't have to do it as a group. If you need that little refresher, or if something's going on, you can do a check-in. So there's other stuff we could do as with the resiliency program. And I have to say it has been very helpful. Each of us get to go at our own pace, and also as a team.
Perfect. Thanks, Sharon. Now, this is a general question for the panel. How about visits with non-English speaking patients? Has there been any issue with access to the internet, phone, etc.? And how are interpreters connected into either hybrid or telehealth visits? David, you want to go?
Yeah, sure. So the several non-English speakers that we have, one in particular, her parent is involved and they always decline a formal interpreter. So it is for our system, it would add a layer of difficulty if that weren't the situation. But yeah, that's the short answer.
Yes. In our center, we actually were able to, so when we were all on the call and we needed, we could send an email to the institutional interpreters and request whichever language, and they would get the invite, and then that interpreter will also join in on the call. So they were there throughout the whole visit, just as one of our team members would be. When we're trying to do it in person, obviously there is a little bit of staffing changes with interpreters in person, but we do have telephone that we can call the interpreters online over the phone and connect them into the room. So that's how we kind of tackle that issue in terms of making sure interpreters are available. We do have a lot of Spanish speaking patients in our center, and most of them, I feel like, were more geared towards coming into clinic. We have tried interpreters with several Spanish speaking families, and obviously the process is in place, but sometimes, with connectivity issues and stuff, it wasn't happening. So I feel like most of our non-English speaking patients were seen in clinic. Anybody else want to add, Abby or Sharon?
I will just say that for quite a while during the pandemic, the interpreters who would usually be in person during clinic visits were restricted from coming into the hospital. And so we could only use the phone interpreters, which I think people perceived as, a barrier to best care. I mean, there was just rejoicing when the interpreters were able to come back. And that didn't happen all that long ago. So and I think the other thing that we saw too is people who, when we had to do mostly telehealth visits, people who didn't want to do video visits, they only wanted to do phone visits. And that was also, I think, challenging for providers to really feel like they got a full picture. They were much happier being able to see people on a video call. So.
Yeah. Moving on, I just wanted to address this issue of triaging between telehealth patients versus in-person visits. I know our center, like I mentioned in my talk, we did that early on to kind of figure out which patient would be adequate for either telehealth. And most of our patients that we picked, either they were set up with like a home spirometer or a infant scale that they could do measurements and weights. So we kind of, as a team, we looked at the criteria, and then our schedulers, our nurses, if they got a phone call, we would kind of pull that list back up and sort of say, do they fit all of this? And then also we took into consideration family preference. We were still seeing our clinic never shut down during COVID. So we were still able to see patients who really wanted to come in. So that's how we determined, who got to do what. And I know there was a question about healthier CF patients now on, Trikafta. Yes, most of our patients are doing a lot better. So we were more comfortable with doing telehealth visits. And although there hasn't been a formal sort of policy or guideline that's gone out, but we're sort of offered 2 telehealth visits, or every other one come into clinic so we can get labs and things, especially if it's a new start on modulator. So I think our families are pretty content with that compromise. So that's how we do it. I don't know if any of the other panelists want to speak on that.
I can talk about it a little bit. I was very envious of your prioritizing. I think we're going to adopt that. One of the things that has evolved in our clinic is for, telehealth. We loved telehealth for a while. And then all of a sudden we were like, wait a minute, we don't have any like real PFTs or cultures. And so we started to schedule patients for PFTs at a time other than their telehealth visit. And they would actually go into one of the clinics. It might be a satellite clinic to do PFTs. and also get cultures there if possible, or come in separately for cultures or labs. And then that information would be available either during the telehealth visit or soon after for the provider to use. So, kind of another variation on the hybrid. But that has been working well. And now we're working to kind of track that, as the year end is coming, who's had what, and, who needs to get prioritized to either come in or have one of those alternative hybrid lab PFT visits.
Perfect. Thank you, guys. So Phoebe, question for you. The resiliency training handouts, are they available for patients at all, or is that something that's in the works?
Yeah, potentially. We started turning our content into comics during the pandemic because we were sending out tools kind of hospital-wide for people to use to kind of manage some of the difficult emotions that were arising when the pandemic first started. And we knew that people were really tired of reading memos because we were getting a lot of memos and a lot of emails at that time. So we decided to turn our tools into comics. We haven't intentionally distributed them to patients, but I have heard just anecdotes of people who've taken the training. I know in like rehab, people have posted some of the comics and the tools so that their patients can see them and they can kind of practice them together. So I think that's the next step for these things. And they're very like kid friendly, obviously, because they're cartoons. So yeah, I'd love to see more of it being used with patients for sure.
Perfect. I know we've had several of our panelists that have had some really cool and kid-friendly handouts, materials. I know there's a lot of requests for these. So if you guys don't mind sharing it, either emailing it to myself or Cheyenne, and we can pass that along so that it can be distributed and available to people who really wanted to use it in their centers. Cheyenne, anything else?
Nope. I think we could probably post some of the handouts on the listserv
Yes.
for people to grab. So if you guys want to send it to Priji and I, we could post it also on the coordinator listserv, as well as whatever disciplines we need to share it with. So that would be great. I believe that is all. Any conclusion notes? We probably finished a little early today.
Yes. Any last remarks from the panelists?
We really appreciate you guys attending. Thank you so much for bringing a presenter. Thank you for joining us. For those people virtually, we hope to see everybody in person. And then I'll let Priji close up, and after she's done, we'll have a little short video, and happy weekend.
Yes, thank you. I just wanted to say thank you again to our panelists as well as our audience. You guys have made this session really great and outstanding. Really hope that you guys got some little nuggets that you can take back to your own center. And we do have a closing little PowerPoint to share, and hopefully we'll see everybody in Philly next year. This brings us to the end of our session. To quote Andrew Carnegie, teamwork is the ability to work together toward a common vision, the ability to direct individual accomplishments toward organizational objectives. It is the fuel that allows common people to attain uncommon results. It is vital to the success of all of our CF teams. We realize this session was a departure from the usual topics at these meetings. However, we recognize that we all work in teams, and therefore it is important to share our skills and ideas in order to improve overall teamwork. Cheyenne and I extend our sincere gratitude to all of our speakers. We also thank all of you for your time and attendance. We hope you will be able to implement and apply some of these ideas into your own centers. I'll end with one of my favorite quotes on teamwork, and it comes from Henry Ford. Coming together is a beginning, staying together is progress, and working together is success. Let's come together, stay together, and work together. Till we see everyone again, stay safe. Thank you.